Uh, Let us move from it is the talk of pressures. Let us move from the portal pressure to oncotic pressures. And our next topic of the discussion is by virtual presentation. And it is on the albumin, role of human albumin in the decompensated liver disease. For that, our speaker is Dr. Nadeem Tehami. Dr. Nadeem is a consultant hepatologist and hepatopancreatic medicine consultant at the University Hospital, Southampton, NHS. He has a major interest in the endoscopic endohepatology and pancreatobiliary diseases, and he performs the advanced endoscopy including EUS and ERCP. He is an endoscopy education and training lead in his trust, and he is the faculty on the JEG and hepatobiliary endoscopy courses. He also is actively involved in the training endoscopy overseas, including the participation as a faculty on the Asian EUS group courses. He is a core member of the Wessex group on the ERCP and EUS group, and he sits on the pancreatic section in the BSG. So Dr. Nadeem has ongoing clinical training and research interest, including the interventional EUS and ERCP, chronic pancreatitis, and IgG4 related pancreatitis. So, for his virtual talk on the role of human albumin, whether in the decompensated liver disease, whether it is a friend or foe, I will request the IT team to start the presentation.
Assalamu alaikum and good day to you all. I'm very grateful for the invitation. I'm genuinely gutted that I'm not there physically to attend this fantastic program and meet you all. Title of my talk is Role of Albumin in Decompensated Cirrhosis, and in next 15 to 20 minutes I will try to answer the question, should we continue to regard this as our friend or not. I have no disclosures. I was pleased to have received this invitation to talk on this subject because to my mind it reminds us of the basic principle, that is, first do no harm. Now, to discuss this topic I will have to share some basic knowledge which you already know, so spend few minutes on back to medical school, and then based on our current understanding and knowledge we'll try to answer the question what extent albumin has any role in decompensated cirrhosis. I hope that by the end of the talk we have a clarity of concepts, and we should be able to stop abuse of albumin, if any, in our current practice. So albumin, as you all know, is responsible for 70 to 80% of the colloid osmotic pressure of normal plasma. It is the most abundant plasma protein, representing over 50% of the total protein content. It is a monomeric protein of 66 kilodalton composed of alpha helices. If you look at it from my eyes, then it is the heart of our liver. Its functions can be divided into oncotic and non-oncotic functions. We know that it binds and transports endogenous and exogenous molecules, binds nitric oxides, bile salts, toxic substances, and drugs. It interferes with the neutrophil adhesions to the capillary endothelium, reduces capillary permeability. It contains thiol group, a free radical scavenger, and its immunomodulation through which it rescues the immune function. From pathophysiology point of view of cirrhosis and decompensation, it's the arterial vasodilatation in cirrhosis, which results from increased production of the vasoactive substances such as nitric oxide, carbon monoxides, endocannabinoids, which induce vasodilatation, which hampers the vascular response to vasoconstrictor. This all leads to effective hypovolemia, which then evokes the compensatory activation of neurohumoral systems, including renin-angiotensin system, and as a result leads to vasoconstriction and venal retention of sodium and water. Albumin, through its various functions, is able to exert an important influence in this pathophysiology and is therefore regarded by some as a disease-modifying agent. What we also know that acute and chronic liver failure is a large healthcare and economic burden with increased mortality. We know that the low serum albumin does not equate with malnutrition. Most of us have seen patients with anorexia nervosa who have normal serum albumin. Albumin is a pleiotropic molecule that, in addition to volume expansion, has anti-inflammatory properties that are believed to explain its beneficial effects in these clinical settings. There are established indications and guidelines from international societies. We all use albumin for three common indications. Firstly, to prevent post-paracentesis circulatory dysfunction, mostly after large volume paracentesis, and try to avoid it in limited volume paracentesis, that is when we drain less than 5 liters. We also use it in treatment of spontaneous bacterial peritonitis with antibiotics as per European and American guidelines, and administer it in management of patients with hepatorenal syndrome in conjunction with depressin. There are some other indications which are regarded by some as controversial, and these are beyond the remit of the talk today. I know I'm speaking to the audience where majority regard albumin as a friend. So do I. However, when you come across advertisements such as this, gives a sensation that there might be a marketing department which is going desperate. When you speak to the experts, some believe that we often do more harm with albumin over administration than good. If you look at practice elsewhere, for example, in cardiac surgery, after publication of albumin in cardiac surgery trial, the albumin use reduced significantly, which was translated in substantial cost saving. Now, it is incredibly important because majority of us work in resource limited settings. And if there is one take home message from today's presentation is that we should be using our available modalities, products, resources judiciously to benefit our patients across the board and protect the system that we work in. Again, a basic reminder that cirrhosis is decompensation is defined by a presence of ascites, variceal hemorrhage, hepatic encephalopathy, or a combination of these disorders, and a stage of further decompensation occurs when the development of complications of the complication, such as refractory ascites, recurrent variceal hemorrhage, hepatorenal syndrome, or a combination of these. If I were to ask you what precipitates this, I know a majority of you will be able to explain that this is the inflammatory states, most commonly bacterial infections, or alcoholic-induced hepatitis, which are the common precipitants of further decompensations and complications such as hepatorenal syndrome. The problem that we have is that majority of these infections in patients with cirrhosis remain culture negative. Patients do not mount a typical SIRS response, and the reason for that is because these patients have reduced baseline neutrophil count, elevated baseline heart rate due to hyperdynamic circulation, may have baseline hyperventilation due to underlying encephalopathy, and do not mount a good inflammatory response when faced with infections or inflammation. Therefore, the available SIRS criteria and the biomarkers do not differentiate infectious versus non-infectious SIRS. This cartoon demonstrates that the oxidant-mediated injury leads to production of TNF-alpha, which activates the oxidant-sensitive transcription protein complex, which promotes inflammation. Albumin preserves cellular glutathione, downregulates the TNF-alpha production, thereby protecting cells against oxidant-mediated injury. TNF-alpha is extremely important. It is a validated marker of monocyte functions in critical illness. Patients with acute decompensated cirrhosis have high level of infection due to inappropriate immune response, which we all know is multifactorial in etiology. Now, there are different ways by which immunosuppression is mediated. If you look at the role of prostaglandin E2, their level is 7 times higher in acute decompensation. And with reduced albumin, it leads to dampen TNF-alpha production by macrophages. So in this study by O'Brien and colleagues, when intravenous albumin was administered to improve serum albumin, they were able to demonstrate that the functions of macrophages were restored and TNF production, alpha production was restored. The similar concept was demonstrated by authors in this study, where high albumin dose versus low albumin dose improved the serum albumin level and also decreased inflammatory cytokines. So the blue lines or the blue dots represent the high albumin dose, where the red dots essentially shows the low albumin dose. The conclusion was that the high albumin dose does attenuate inflammation. Now, based on that, if you look at the available data, so on this slide, I have summarized the three important relevant studies. On the left, you see the ANSWER study. This was the only positive study, but it was not a placebo controlled and only looked at the patients in the outpatient settings, compared to MAC and the ATTIRE studies, where the inpatients with acute decompensation were looked at, especially in the ATTIRE trial. And in the ATTIRE, the goal was to prevent infection, kidney failure, and death through daily intravenous albumin infusion. It was an open label, randomized controlled trial, nearly involving 800 hospitalized patients with decompensating events. Patient had daily albumin infusion to maintain a serum albumin level of at least 3 grams per liter throughout their stay in the hospital. This was compared with the standard of care arm, where albumin was only administered for established indications such as to prevent post-paracentesis circulatory dysfunction, SPP, and treatment of HRS. Trial did not show any significant difference with respect to the composite endpoint, which I mentioned were infection, renal failure, or death, comparing with the standard of care. In fact, in patients in the albumin group who received 10 times as much albumin as in the standard of the care arm had more severe or life-threatening serious adverse events, especially pulmonary edema and fluid overload. This was consistent with another study which was published back in 2015, where albumin was used for infections other than SPP. And it was again found that the higher dose was associated with pulmonary edema and did not improve survival at 3 months. Now, colleagues across Atlantic Ocean were pleased, or as they tell me, after FDA approval for terlipressin, based on the findings of the confirmed trial, which was a third generation trial and was first to show that percentage of patients who had HRS reversal was significantly higher among those who received terlipressin than among those who received placebo, so 32 versus 17%. Unfortunately, respiratory failure occurred in a higher percentage of patients who received terlipressin. It was a finding similar to what was seen in a ATTIRE trial. Respiratory failure probably resulted from pulmonary edema, which must have been caused by increase in afterload from terlipressin, and increase in preload from albumin, which was used in 83% of patients in the terlipressin arm. So going back to what we know already, or the EASL recommendations, where quite a significantly high doses are recommended to be administered on day 1 and day 3. This was based on this trial, which did show reduction in infection, hospital mortality, and renal failure in patients who were given antibiotics with albumin. But important thing to note is that the dose of albumin in this trial was empirical. And therefore, in patients with SBP, one should tailor the dose of albumin based on presence or absence of acute kidney injury. Ideally, using some objective method to assess volume repletion, such as point of care ultrasound, which majority of our colleagues in emergency medicine use these days. So the message that I want to give from this slide is that the SBP dose should disappear. So a quick slide on point of care ultrasound, which is what our colleagues in emergency medicine utilize, a focus ultrasound scan where we can look for signs of portal hypertension and can also look for signs of volume overload. Now, I know my colleagues in radiology have other tools available and other better modalities available these days to help. But the point of showing this was that this focus ultrasound should become our fifth pillar of physical examination. There are miniature ultrasound probes available which can be linked with our smartphones. And this is what is the future is. You may have seen this news where medical school inductees were given handheld ultrasound rather than stethoscopes on their white coat ceremony. We've discussed so far that albumin is causing volume overload and causing lots of problems, but decrease in the cardiac output leading to an exacerbation of effective hypovolemia is also observed in patients with severe liver disease, suggesting clinically relevant cardiac dysfunction in patients with the higher end of the spectrum of cirrhosis, which gets better or improved by IV albumin. Is it only by improving the preload, or is it more to it? Now, this animal study shows that by administration of the albumin, although it's an animal study, but they were able to demonstrate increase in the cardiac contractility with albumin infusion, i.e., it has an additional role in improving cardiac output, which we probably will know more in the future. But why are we so criticizing albumin when it has so many potential advantages? The available albumin, if I look at two main available formulations, we have 5% or 4.5% albumin, which comes in 500 or 1 liter bags, compared to salt poor albumin, 20% albumin, which comes in 50 or 100 ml bags. So there's a substantial difference in terms of the volume. If you also look at the sodium content of 4.5 or 5% albumin, it is essentially the same as we have in 0.9% saline bag. Patients with cirrhosis, some of them, majority of them in fact, do not excrete much sodium. So if you end up giving them a liter bag containing about 150 millimole of sodium, they may end up taking 2 weeks to excrete that amount of sodium. Therefore, essentially 5% or 4.5% albumin is as bad or as good as the 0.9% saline. So if it is all to do with the volume, and I think this is where this study helps, because it shows that by using 20% albumin, the amount of the fluid required to resuscitate was substantially less, and they were able to minimize the positive fluid balance without any significant difference in the harm comparing with the 5% albumin. So less volume does seem to contribute, and that may be one of the contributing factors when the complications were mentioned in the studies earlier. So we can probably conclude on that basis that we can safely use salt poor albumin if we objectively measure the volume status of our patients. It can be administered in patients with spontaneous bacterial peritonitis, probably not in the other indications, and we need to be very careful in terms of the dose that we are administering to our patients. So, Chairperson, ladies and gentlemen, we conclude that randomized controlled trial showed lack of benefit of daily HAS in hospitalized patients with decompensated cirrhosis with potentially lethal cardiopulmonary complications. But on the other hand, other trials confirmed showed benefit of 30% with albumin in reversing HRS. Therefore, we should tailor treatment to physiology, be precise, be objective, and consider other modalities such as point of care ultrasound. Overall, the focus should be on the rational use of the albumin and be guided by the clinical picture of the patient. Thank you very much for listening, and I will look forward to question and answer session.